Welcome everyone to WeScience. At WeScience, our goal is to promote local science on a global scale. Today we have a special guest, Dr. Francois Rwandamuriye. Dr. Rwandamuriye has a PhD in tumor immunology, and he's a postdoctoral research associate at the National Center for Asbestos-Related Diseases. Thank you so much, Francois, for accepting my invitation to be part of this podcast and learning your journey as well as your science and your vision for your science. Thank you.
Thank you, Carlos. I'm pleased to join you to WeScience to discuss about our work, our journey, and our way to make an impact in science. Thank you.
Thank you, Francois. So I just before we go into science, into your science, I just wanted to know about your journey. So what was your first memory of wanting to become a scientist?
For my memory to become a scientist, I think it's not when when kids, maybe some kids have some have that curiosity wise of becoming a scientist. For me, I think it became into my career wise because I did my PhD in the middle of my career, so I have been working as a professional in the government, and then at one point I decided to do my master's and PhD. Then when I was doing my master's, and I was doing a master by research, so that's where actually I found research, curiosity in research, where actually you can discover things, how things work, and change into real life impact. I think my decision coming to in the middle of my career, because I mentioned I did my PhD when I was mature, so it's not something I had when I finished high school. So it became into the journey of my professional career.
So you are originally from Rwanda. So then you moved to South Africa, right? So it was anything that was sparking there that interested you to become a scientist? A scientist?
That's a good question. I'm original from Rwanda, and that's where I grew up. And I did some of my education in Rwanda until when I did my diploma, and it was in biomedical sciences. Then I want to continue. Then there was more opportunities in South Africa, so I went for South Africa to continue my honors. I honors because in South Africa, the research is more developed compared to my country at that time. So I joined the University of Johannesburg and to finish my undergrad, which was on as the fourth year of my undergraduate. So actually, that's yeah, also sparked my passion for research, because I had this amazing teacher about molecular biology, where we had a year-long unit of doing molecular biology work here, like cloning, DNA, PCR. So that, as an undergrad, I found actually that I have that passion of doing science, a real thing where you can see, actually, you can amplify DNA, you can see proteins by Western blots. So that actually was also one of the turning points in my career to decide to do research.
Yeah, as you know, I'm originally from Colombia. So, and the first memories that come to me in terms of the science, as you were speaking about molecular biology and the DNA extraction. So, do you see any difference when you were in South Africa and then you moved to Australia in terms of molecular biology? Particular for me was, for example, the extraction. It was very manual. How you do extractions of DNA in Colombia. So I just wondering if in Rwanda or in South Africa is something similar.
That's a great question, Carlos. Thank you for. I think education in science is a bit tricky. It's not like teaching history or geography. In science, you need the laboratories, you need the infrastructure, you need and all those things. You need the money to set up good laboratories. So from Rwanda to South Africa, obviously there was difference in what infrastructure you can use to teach students. For example, in terms of a machine, special machine, for example, and other machines or equipment which are required to do science. Then when I moved to Australia, I moved to do my master's, which was master's infectious diseases. So also I found actually there were more infrastructures compared to South Africa. And that's the reason behind, when you move from your country to a more developed country, so you want to get access to a developed education. So there's always differences in terms of infrastructure, also qualified teachers who can transfer that knowledge. So that's what I can. There's always differences between those countries.
Yeah, in particular in third world countries, doing molecular biology research is very manual. Everything is very manual. So even watching the tubes, etc., is no in countries like Australia, we are very lucky to have a person who watches, etc., and we have kits and we buy the kits, etc. But in third world countries, everything has to be from scratch.
Yeah, it has sometimes it's basic. Carlos, also time, there's also matter of time because, for example, 10 years ago when I did my undergrad, things have changed now. There's new technologies in sequencing and, every aspect of biology. There's technology is more advancing compared to the 10 years ago.
So you said that you moved from from South Africa to do to Australia to do a master's. What was your main motivation to move to Australia?
It can be twofold motivation. First was opportunity because you education is very expensive in Western world, as you know. And so there was an opportunity for a government-sponsored scholarship between the Australian government and government of Rwanda. So then that was one motivation. The second motivation, the course that I wanted to do, which was a Master's of Infectious Diseases, it was here in Australia. So that's twofold. And maybe going back, I chose to do Masters of Infectious Diseases because by then in Rwanda I was working in health sector where I was the quality manager of the microbiology testing laboratory for blood products. So always we were concerned with infectious diseases in developing countries. So those combined together made me come in Australia to do my master's.
Yeah, and then you came to Australia to do your master's in infectious diseases at the University of Western Australia. So what sort of challenges do you face when you arrived to Australia? Do you came alone or do you came with your family?
Challenges can be so when I came by myself in the first year. So it's hard when you migrate from your country to another country. Sometimes it's a new way, new world. So I decided to come by myself, and so that I can adapt in my studies. Because the primary motivation of coming, primary responsibility was to do my master's. So I came by myself for the first 9 months, and then the family joined me around the end of the year. So the main challenge, obviously, when you move by yourself, you leave the family home. It's you miss your family, you miss your nuclear family, and sometimes you are responsible for most of the things. So that's what was one of the main challenge. The other challenge was to adapt to the new system. When you move, Carlos, you are in a new country, you don't have friends, you have left all your friends, your family back home. So there is a challenge of adapting to the new system, to have a friends. And then another challenge, you have more responsibilities, education, you have to focus and so that you can do well in education. So all the multifaceted challenges.
One of the things that, and you remind me of this, is that when I was in Colombia, I was trying to trying to get some funding to be able to get to buy a real-time PCR machine, which at that time was very expensive. It's still very expensive, but a few labs in Colombia they had the opportunity to have that particular system. And then when I came to Australia to do my PhD, so my supervisor, she was like, we had two real-time PCR machines, and then she had a meeting, and she said, okay, how many PCR machines, real-time PCR machines we need? Do we need two or maybe four? And then in Australia, it's like a difference in terms of what happens in what I saw in Colombia and here is that we had four real-time PCR machines at our disposal, whereas in Colombia I was fighting to get some funding to be able to buy the cheapest version of the real-time PCR machine, and
Yeah.
that's a very breaking into the two worlds.
Let's bring us, back to the question, why do we move? There's always difference in terms of financial capabilities, which translate to how many infrastructure can you have, and that affect the education you can get. If you are struggling for one PCR machine and you have 35 students in a classroom, how can you make people share one PCR machine? And the education, the output will not be, as efficient as someone who has the enough infrastructure. Yeah, that's the basic problem. Yeah.
How was your transition between doing masters when you finished the masters and then finding your first job in research?
In research, yeah, that's a good question, because when you come here, you do your masters, finish. Finding your job is not as straightforward as you might think, because you need connection for references. So when I finished my masters, I think I spent like 1.5 years looking for professional job. I was just applying different places, applications. So one of the challenges I met was whenever I applied for a job, there was a problem of Australian experience. So always they asked me for, you don't have Australian experience. But before doing my master's, I have been working for like more than 10 years actually. So that experience didn't count in terms of Australian experience. So then my question was, how can you get an experience when you haven't been working? That was a dilemma. At the end, after 1 to 2 years, I managed to find a research assistant position in a lab. Yeah, that's a big challenge, to find a lab that can trust your knowledge without having experience. Yeah.
So you doing the masters, I think, sorry, after doing your research at Murdo, I think it was, uh, then you moved to the sarcoma translational group at the kids. So how do you make the transition from as a your research position to then jump into the sarcoma team?
Yeah, that's a good question, guys. When I was working as a research assistant, I think I worked at Medoc University. I was working with a group doing a research on drug hypersensitivity reaction. When people take medicine, sometimes they get allergy to different medicines. So we were trying to study the immunopathogenesis, how those reactions happen. So yeah, I enjoyed that time doing research. But my passion, my goal was to do research PhD in immunology, specifically tumor immunology or infectious disease immunology. And through the way of doing working as a RIA, I always thought I have to do PhD if I want to progress further into my career and just do more things I want to do. I approach different researchers that I can do PhD with. So, but in the area of tumor immunology and infectious diseases. So one lab I applied was in Melbourne. So there was a lab which was researching on infectious diseases at the University of Melbourne, and also I approached the team at Telethon Kid Institute in the sarcoma team. But approaching that sarcoma team came because I met one of the researchers at Telethon Kids who was presenting at Medoc, and he was giving a talk about immunotherapy into sarcoma. And I got interested actually in the talks and the person, how he was very enthusiastic and motivated. So I also contacted that person. So at the end, I got scholarship to go to Melbourne, but which came after I have accepted the scholarship from UW to go to Telson Kids to the sarcoma group. So that's how I joined the sarcoma group in Breathe. Yeah.
Yeah, fantastic. And the Sarcoma Translational Group is a very successful research group in Western Australia as well as in Australia. It has uh, produced a lot of pioneering papers as well in the fields of sarcoma and tumor immunology. How do you explain sarcoma and tumor immunology to a person that is not familiar with science?
Starting with the sarcoma, it's a cancer which it's not known actually in the community like people know leukemia or brain cancer. Sarcoma is a rare cancer in adults. It's a cancer which mostly happens in young adults and kids. It's a cancer of what we call connective tissues, like in the muscle. So it happens in the muscle or in the bones. Sometimes a kid or a teenager will be having some pain in the joints or in the knees or in the muscle. And sometimes they can feel a lump, growing into the muscle. So they will finally find that it's a sarcoma tumor growing in the muscle. So it's different from other cancers that we know, like leukemia, which grow in the blood, or other skin cancer. So it will be mostly found when someone is feeling some pain in muscle and the bones. So as I mentioned, it's common in young adults, and the treatment always will be surgery to remove the tumor. And now that the treatment has advanced with the surgery, initially before the treatment was to remove the limb which was affected, but now surgeons try to spare the limb so that they can remove the tumor by sparing the limb. So then immunotherapy comes, because despite the use of surgery, so the tumor will always most of the time grow back. And then in the research we were doing in the sarcoma, we're trying actually to use the surgery when the surgeons take out the tumor so that we can apply immunotherapy to prevent the tumor to come back. So the immunotherapy would boost the person's immune system, because we have the capacity to kill, for example, to fight against some viruses which infect people. So you can use that capacity of the body, which was developed to fight, for example, cancer, so that it can fight the remaining cancer cells using immunotherapy. So that's how our research of immunotherapy and sarcoma and the surgery came into play.
Okay, so basically but my question is in regards, for example, if there is a tumor, the tumor is part of the body, right? So the immune cells cannot recognize the particular tumor. So what the immunotherapy does to be able for the immune cells to be able to recognize what they were not recognizing before? How do you able to sort of train or
Yeah,
trigger the response against the tumor?
that's a good question, Carlos. In the immunology or immuno-oncology, the immune system does recognize the tumor. We call it immunoediting. The immune system is recognizing the cancer cells, because cancer cells, they are growing, so they have markers which differentiate them from normal tissues. So the immune system will try to recognize those markers, but over time the tumor evolve and escape the immune system. So there is immune escape, where actually the tumor growth outweigh the capability of the immune system to kill the cancer cells. So that's what happens. Then with immunotherapy, you are trying to train the immune system to be more active so that they can actually fight the cancer cells. So you can use that in different ways. The most common used way for immunotherapy, we know what we call immune checkpoint blockade, because one of the way the tumor can evade the immune system. So the immune system has like breaks so that it can stop overacting, because if it overacts, it can can destroy the person tissue cells. So there are kind of breaks so that when it does go wrong, so there's some kind of breaking, stopping. So that's one of the way the tumor, the cancer cell used to escape. So then one of the immunotherapy is to use the immune checkpoint blockade to remove those breaks so that the immune system can actually act more efficiently. Another way for immunotherapy is to use to take out cells from someone, the patients, and engineer those cells and put them back so that they are more efficient in killing cancer cells. So another way would be to find, some drugs that can target some receptor on immune cells so that they can come out more active than they were initially. So in summary, the immunotherapies try to boost the capability of the immune system just to recognize and kill cancer cells. So it has been effective in some cancers, as you know, in melanoma, lung cancer, but there's always a problem because each patient's capability to kill cancer cells is different. So some patients respond and others don't respond. Some cancer respond and others don't respond. So that's the way researchers are trying to boost, to make it more efficient.
So what makes a particular patient to be able to respond and the others not be able to respond?
That's a good question, because do I know? I think it's a question hard to answer. One think it really depends on the cancer. Within the cancer, then if two patients have the same cancer, each cancer is different from two different people. There's different mutations in each cancer, in each patient's cancer, and then we have problem of what we call cold and hot tumors. Some tumors are more infiltrated with the immune cells, whereas others are not infiltrated with the immune cells, and all those factors will determine if the cancer will respond or not. So in summary, there will be different biomarkers, different mutation in each cancer type, and different filtration of immune cells, and all the other factors, inherent to the cancer, which will determine the response.
Yeah, what is interesting of what you said is that particularly because, as you know, the cancer, it comes from a particular cell, one cell that became mutated, and then it gained uncontrollable proliferation advantage. It grows without control, basically, and then it grows, then it started to produce other cells that they are different. So that's what we call tumor heterogeneity, basically, that the different cells come in with different mutations, etc. So what you say is that the immune system is sort of in this balance, like trying to be in equilibrium in terms of the cancer being multiplying, creating different type of cells, and the immune cells be able to recognize the new cells
and then the cancer
see, and
cells,
the cancer cells sort of like dampen the response, so they can still survive. It's like a coexistence between the tumor as well as the immune system.
Yes, that's a question. That's sometimes there's a balance where the tumor don't grow and the immune system doesn't eliminate, but there's a point where actually the tumor will overcome the immune system, then some escape. That's where you have tumor growth in which can't be controlled. Yeah. So
And as you
it's a survival that, cancer said that's trying to survive and doing tricks, on the level of mutation, on the level of dampening the immune system. All those factors, lead to the escape of tumor.
because, for example, you were saying about these checkpoint inhibitors, like the tumor cells, they express them, be able to sort of reduce the immune response, but also the cells, as part of their oncogenesis or a part of their malignancy per se, they sort of then regulate the expression or reduce the expression of a particular uh, proteins that are trigger the immune response. So basically, they express less antigens or less proteins in the surface, so that they can be less recognized by the immunosurveillance or the surveillance of the immune cells.
Yeah, there are many factors. Also, the tumor markers to be recognized by the immune system, they need to be presented at the surface of the cells. Another mechanisms cancer cells use is to downregulate the proteins that make the antigen to be presented at the surface of the cell, so that the immune system can't recognize it. So there is many factors that drive the tumor resistance, and then the researchers trying to understand those factors so that actually can target those pathways just to boost the immune system.
You were saying about the sarcoma that when a person was diagnosed with a sarcoma, they had to sacrifice the limb to be able to sort of save the people's lives. That remind me that in early ages, like early centuries, the practice for cancer at the early stages, it was sort of like the same procedure, because there was no treatments available. They had to sort of chop parts of the body to prevent the cancer to come back, and they were able to do that. So what you said, it reminded me of the very early stages of history of cancer, where the clinicians were trying to find ways, and what they found is that even though they were removing parts of tissues, the cancer sometimes it come back and it was more aggressive, and that's something that when the therapy came, the first therapies, they were able to sort of improve the survival of those patients and prevent those very drastic ways to do that.
Yeah, that's okay. The history of cancer, it's a long story, and but what we can get from this, that technology is being advancing, the medical field is being advancing, so that there's always more breakthrough which have happened.
And
that make treatment better. If someone at least can survive from cancer, at least they have the limbs. That's that's the lifestyle of the patients after cancer treatment is. It's also one big factor to consider. And another thing, the way we are looking for immunotherapy, part of surgery, we have chemotherapy, radiotherapy, which are more toxic, and most time patients will have long life side effects. And if we can find new therapies where we can actually have less side effects compared to the existing treatment of killing radiotherapy. So that's another motivation to find new treatment approaches.
Yeah, fantastic. So let's go back to your research. So in your PhD, please tell us your research, what was about, and what was so pioneered about it.
My PhD research, as we have been discussing, that my team was working on the intersection of surgery, immunotherapy, and sarcoma within sarcoma. So my research was to use surgery as a window opportunity so that you can apply immunotherapy. Normally, immunotherapy, as you know, is delivered by what we call systemically. They infuse the immunotherapy in the bloodstream, IV delivery, and that's the problem, is not targeted. You will have side effects because the immunotherapy will go all over the body. So one of the problems, they have to use more high dose to reach the required dose. So then the problem is toxicity because it will go all over the body. So then if we can use that time of surgery and apply immunotherapy at the site of tumor where the tumor was removed at the time of surgery, that would be a very innovative approach. My supervisor came up with an idea to develop a biomaterial, kind of a gel, like a hair gel, that you can put in a immunotherapy, and you can apply that gel in the wound after removal of the tumor, so that the gel can release the immunotherapy slowly when the gel is degraded. So the gel could be degraded by enzymes in the wound environment. So that was innovative approach, just to deliver immunotherapy locally when the tumor is removed, and so that the immunotherapy can be released slowly, and that prevent problem of toxicity because you have a low dose of immunotherapy which is being delivered. So mainly that was the main objective of my PhD research. So we characterize you need the gel that can be applied in the wound. If you apply a gel which is more, for example, liquid, that can go out when you close the wound. So we need to come up with a gel that can be applied in the wound and stay there for the required time. But also we didn't want the gel to stay forever. It has to be degraded so that it can't stay. If it stay in the body, that was not good. It can be taken like a foreign body. So the question of having a gel that can be degraded slowly and be removed when it's finished. So that was, it was part of the research.
Yeah, fantastic. So for how long the gel has to stay there and for the immune therapy to be effective?
Those maybe it's part of the work has been published, but we could show that the gel could stay there for like around 2 weeks, and the drug could be released for 2 weeks, which is enough for the immunotherapy to act. Yeah, so we published the work, and the team, also my supervisor, patented their work so that we can pass through the commercialization of the innovations. We show that the approach was effective. So we could show that actually that approach could prevent the cancer to come back when the cancer was removed. And we also, one of the parties to characterize the mechanism, how the gel and immunotherapy is working, which immune cells are coming, which biological pathways are being activated. So we could characterize all those aspects. Later on, the pathway, we went through just testing the immunotherapy in other aspects.
I guess it wasn't just for for sarcoma. It works for it works for all type of cancer where there is a surgery and melanoma, etc., breast cancer. That it will be a surgery removal, and then you can apply the gel. So you show a fantastic principle that works. That instead of putting immunotherapy through IV and expose the whole system to the immunotherapy, then you just localize the immunotherapy to the particular place where you want it to work on.
Yeah, that's the concept, Carlos. There's a say that's think locally and act locally. You are acting locally where the problem is. Yeah, and it has to be more effective if you have a way. And another thing, another innovation behind. So you have the patient there, you remove the cancer, and you apply immunotherapy. You don't have the patient to come back more times as it's normal for other immunotherapy, where you have to infuse patients with immunotherapy for several weeks. And that comes with the problem of adherence when sometimes the patient is not feeling well, they don't come to continue the treatment. But with the aspect of the gel and surgery, you can actually apply the gel at the time of surgery. And as you mentioned, it can be applied to the other type of cancer where you have surgery as main treatment, especially, for example, the cancer which are not located in deeper organs like head and neck, sarcoma, obviously, those type of cancers.
And with that fantastic work, you were able to get awards and grants. You got a Cancer Council of Western Australia grant, and I just wanted to know which factors you got your PhD in 2023, so it's been 2 years. So, what factors contributed to your success as a PhD student? What do you think was key for you to be that successful in terms of research?
In terms of research as a PhD student, I think I may say mostly it's having a good team, a passionate team, which has actually purpose and a mission, and which also supportive. My team was very supportive. My supervisor is a very hardworking, enthusiastic researcher who is a great leader who can motivate every person in the team. So there was big motivation about in the team and support from all members of the team, all members supporting each other and having a shared mission. So that I can attribute the success of a team to the team coming together and having a great leadership.
But also hard work, right? And the family as well.
So Carlos,
Hard work and family.
hard work. Yeah, you did mention I did my PhD when I was mature enough. I was I was an old guy doing a PhD. When you are doing a PhD, there's also sacrifice. I was saying that team leadership on the side of my side as a student, you have to work hard, because you have that's a problem page. You have set time of 3 to 4 years to finish the project, which is not enough. You have to work hard over the weekends, and then there's a trade-off with the family, how to balance. Yeah, but sometimes you have also to give family time, but you need to work also hard to achieve the goal. Yeah.
Yeah, fantastic. And then after you finish your PhD, you work there for a year or so. Then you change the cancer type as well as you change the immunotherapy. Could you please tell us now what's your research about? I know that you're working in immunotherapy, but you're working in mRNA.
mRNA, that's the whole that's the whole topic, Carlos. Yeah, when I finished my PhD, when you finish PhD, you always you want to do a postdoc in another laboratory. There's always I always give an analogy of a teenage. When you have a teenage girl or a boy, sometimes they have to move home and go somewhere so that they can, experience life. So I had to look for a postdoc in another lab. And in the transition, I was working with the lab and finishing some project and writing up the manuscript for publication. So I worked with the sarcoma as a postdoc for like a year and a half, finishing those papers and finishing those projects. And looking for a postdoc for more opportunity in the East Coast, like Melbourne, and also having a family, teenager finishing high school, didn't take those opportunity, family balance. So then this opportunity came at UWA at the National Center for Asbestos-Related Diseases. So doing research in mesothelioma, which is a cancer caused by asbestos exposure. So they were just setting up a project to use mRNA for immunotherapy for mesothelioma. So then I found very interesting in my area of experience, immunotherapy, immunology. So that's how I joined the group.
Right. So you mentioned about mesothelioma, right? That's a type of lung cancer. Could you please expand a little bit about that?
Mesothelioma is a type of lung cancer which is caused by exposure to asbestos. It's a very contrast to the cancer I was working in the sarcoma, which I mentioned is cancer for young adults. Mesothelioma most happen later in life because it's a long developing cancer. It happens people who have been exposed to asbestos. As you know, asbestos used to be used in the construction, but now they have banned the use of asbestos. But there was a time where people were exposed to asbestos without knowing the cause. So all those people, that cohort of people, so they have been developing cancer later in life. So the cancer develop in the lung, in the lining of the lung mostly, that's why we call it mesothelioma. And it's a bad cancer too. And we are trying to find treatment. And because the location in the lungs, surgery is not applicable. The first line of treatment actually now it's immunotherapy. So now we are trying to develop cancer vaccines to boost the immune system by using mRNA. As you know, the success of mRNA with the COVID vaccine, now we know that you can use mRNA to make any protein. So it's more flexible and it can scale up more easily. So the success of mRNA with the COVID has made the opportunity to use mRNA for different applications. So that's where we are now. I'm working with researchers at UWA to develop mRNA vaccine.
And so, what are the challenges in terms of mRNA vaccines as an immunotherapy for cancer?
The most challenges is, mRNA biologically, it's an unstable molecule compared to the DNA. DNA is more stable. The mRNA is not stable. So most of the problem is to make mRNA stable so that, when you make mRNA, it doesn't degrade. And when you deliver mRNA, it can be delivered and they make the protein within the required time. So most of the problem is, stability of mRNA, and other part of research now is the delivery. So when you deliver, you do deliver to the part of the body you want the mRNA to be delivered. So that's where you have researchers working on delivering mRNA, for example, in immunotherapy to some type of immune cells, or people working, for example, in liver disease, so that you can deliver mRNA to the liver to avoid off-target toxicity. So that's where most of research are going around, stability of mRNA, delivery. And then coming to immunotherapy, when you deliver mRNA, you don't want to induce the immune system, because when the immune system is induced, it can degrade the mRNA. So you want the mRNA to be hidden, not to be seen by the immune system before it is translated to the protein that you want.
Mhm. So,
Yeah.
what's the principle you mentioned about COVID mRNA vaccine? And you're using the similar principle? What is the principle in terms of mRNA as a cancer vaccine? What do you want to achieve in terms of the
What,
immune system?
that's a good question. In cancer vaccine, there's a big process where, if you remember when we started this conversation, we mentioned that each cancer develops mutations, which are different from healthy cells. So then those mutations, some are unique to each cancer and are unique to each patient. So you can actually detect those mutations. There are bioinformatic ways, and with the new technology of RNA sequencing or DNA sequencing, you can identify those mutations. And with the bioinformatics, actually, you can predict how those proteins, which are made by cancer, can be recognized by the immune system. So conventionally, what they use, they make those proteins, those peptides, and those peptides are delivered to the person so that they can train the immune system. But the benefit of mRNA, if you find those peptides, you can make an mRNA that encodes those peptides. Then when you give the patient those mRNA, so you are making the body an industry actually to make those proteins. So those proteins can be made with mRNA more easily than giving the peptides. And another thing is the scalability. Making mRNA is more quicker than making proteins.
Yeah, one of the people that might watch this or particular podcast will be concerned about the safety. Because around COVID, there was a lot of discussions about safety.
Yeah.
So, how that safety has improved in relation to the COVID vaccine at the time and this time?
Yeah, I think we wouldn't be concerned with the safety of mRNA because for people who understand the biology, we have DNA, which is nucleus. And sometimes vaccines actually have been given by using, for example, viruses which are not infectious, like adenovirus, so that you can encode the protein in a weak virus and then transfer the DNA in the body. Although they are safe, they can go to the nucleus and to integrate into the DNA. But for mRNA doesn't go into the nucleus. mRNA is just transferred in the cytoplasm and translate into the protein and then degraded in the cytoplasm. So there's a safety of using mRNA compared, for example, to use of other technology like adenoviruses. So I think we wouldn't be concerned of mRNA being integrated in the genome because it can't be integrated in our genome. So it's more safer. It's not a genetic therapy as you may think because it can't be integrated in the genome.
Yeah, and as a scientist, we are sort of improving ways to be able to reduce those risks, right?
Yeah. The ways we try to reduce the risks.
Yeah. So I just wanted to ask you, so what are your goals and the impact of your research in the short and long term?
In the short term, research it's a long journey. The main purpose is to make an impact, to find a cure for cancer by doing research in the area of immunotherapy specifically. That's why so in the short term, it's to do rigorous, research so that you can do research actually which can be translated into impactful, life-changing therapies. So it's a long way, but every day I go to work, I know I'm doing my work in rigorous way so that I can make an impact. In the short term, you do work, you publish, you find new way of doing research that can be used by other labs to do their research. That's one of the impacts. It doesn't have to be a big impact, in 1 year, 2 years, but you can discover something that other labs can use. And in the long term, it's translation of research. If you can find new treatment to relieve the burden of cancer to the community. That's the big impact. Yeah.
Awesome. So my last question will be, you are an example of perseverance and resilience. What advice would you give to those thinking of becoming a scientist or to the young scientists?
Or mostly to the people who want to be scientists, young kids. I think you need to have motivation of what you do. You have to like what you are doing, and sometimes people are driven by money. I think that shouldn't be the drive of doing science because if you want to do money, you go in the bank in business, but that shouldn't be the motivation. So you have to have a passion of making change. And another thing I can mention, have to be resilient. There's always, things don't work the way you think every day. And in research, you haven't asked how we sustain research. We always apply for grant. We do publication. There was rejections of grant application. You need to have a thick skin. You know what I mean? So you need to be resilient. Perseverance is important. And motivation doesn't have to be money, although we need the money to survive. And then, willing to make an impact. It can be rewarding because you don't do everything every day. If you are curious, if you want to make things work or do troubleshooting. It's a good career to give you the opportunity to try things and see how they work.
Thank you, Francois, for taking your time to accepting this invitation and sharing your journey, your science, as well as what you expect your science to become. So thank you so much for that. And thank you everyone for watching this episode.
Thank you, Carlos. It was my pleasure to join you and share our experience and the work so that we can actually make change to the people, to the community. Thank you.